The other thing that people get with our practice, and this kind of goes into other problems with the healthcare system with this transparency and cost, is they get access to our prices that we have with LabCorp. So let me give you an example of this. So a comprehensive metabolic panel, through us, when we bill LabCorp and then we pass that bill on to the patient, basically, it's about $4.30. If you go to an insurance-based doctor and they use your insurance to run the labs, that comprehensive metabolic panel will probably be around $100. So that's a massive delta. And if you actually have a good insurance and your insurance says, we'll pay 90% of everything and you do it 10%. Now if that comprehensive metabolic panel is $100, and you owe 10% of that, you owe $10. When if you'd have just had a good cash pay price like you'd have access to through us, you'd have saved $6. And that adds up as we add more labs. An example is I had a patient come in with her lab bill because she chose to use insurance. And we can bill insurance or we can ask LabCorp to bill your insurance if somebody wants. Came in with this bill, $2,000 for everything that was on there. They had pretty decent insurance, but they had $400 they had to pay left over, right? So their insurance covered like 85% of it. I was like, well, had we done the cash pay version, that would have been about $120. So
when my wife and I, we had our youngest, so at that point we were doing a health share, which maybe we can touch on a little bit, and we did cash pay at the hospital, and we saw the original bill of what it would have been to insurance. So we saw what the hospital billed insurance. And I think it was maybe like $30,000 or something like that.
Yeah.
Cash pay, $5,000.
Yeah. Yeah. I mean, this is one of the crazy things in the healthcare world is when you just basically don't invoke your insurance and you say, I want to pay cash, the total price will be significantly less.
Well, I mean, when we talk about the United States spends more on healthcare than any other high-income country. We're obviously not getting the results. But when you see those differences in what you would have to pay an insurance company versus what cash pay is, like that delta, the fact that it's so large obviously indicates that there is major waste, like major overspending, you know, like we talk about America being in debt, like we spend trillions of dollars on the healthcare system, which doesn't work. Like, what are we doing?
So how we got here is like completely crazy. And there's a lot of laws that have been passed over time, right, that have kind of created this complete opaque, non-transparent healthcare system as far as cost goes. And that's one of the things direct primary care tries to change is say, hey, here's your price, right? All your prices up front, right? Here's everything for you up front, right? You know what you're spending, you know what you're going to get, you know all of that. The important thing I think people should understand is most people do have health insurance and they get it through their employer. And oftentimes they have to pay some component out of their paycheck, bi-weekly or what have you. But what they should understand is that when you agree to be a part of some insurance, health insurance, contract, that's basically what you're doing, is you're agreeing to say, like, when I use you, Blue Cross Blue Shield, I'm going to get your prices that you now have negotiated with whoever it is that I'm receiving care from or getting a service from. And you don't have a clue what those are. And oftentimes if you call your insurance company, they're not going to have a clue either. They're not going to be able to get anybody on the phone that can tell you. Because it's all of these secretive contracts that have been negotiated like behind closed doors that set the prices that you're going to get when you invoke your insurance. When you go cash, though, you can go around and you can ask all these places, what's your cost for this? What's your cost for that? What's your cost for that? And it's almost like shopping for a car or something of that sort. Now, obviously, this changes when you're like in emergency care, you need emergency surgery, different story. But most of healthcare is actually not done through emergencies, right? It's mostly done in what we call the outpatient setting, getting an MRI, getting lab work, seeing your regular primary care doctor, now seeing your cardiologist, whatever it may be. And in those environments, you can look and say, like, well, what am I getting and what is the cost? And if people did that, or were at least incentivized to do that, because now they're disincentivized to do it, but if they were incentivized to do it, cardiologists or primary care doctors who would charge an arm and a leg would be like, no one's coming to see me. I got to drop my prices, right? It's like if you try to sell a Toyota 4Runner for $300,000, and like, I'm not buying that from you, right? Why would I buy a $300,000 Toyota 4Runner?
Right.
I'm going to go buy the $50,000 one over here.
Right.
So the lack of the price kind of sensitivity creates these prices kind of creep up over time because they can. And a lot of the structure of it incentivizes this price creep. And then you end up like, most people then end up looking at their insurance company and saying, they're charging me an arm and a leg every month. I'm like, yeah, but then the contracts are horrible. And that's why they're charging you so much because, they're trying to make 10, 20%. and the hospital's making them pay, you know, an arm and a leg for whatever it is you're getting. But at the end of the day, you're still getting screwed. So yeah, the insurance company is the problem, the hospital system is the problems, but the structure of it's really the problem.